So, welcome to the Penny Drop podcast. I have with me via Zoom is Dr. Henry Ramirez, gynecologist specializing in urogynecology, along with all of this innovative stuff that we're going to be talking about today from beautiful Ardmore, Oklahoma, southern Oklahoma. Just how many miles north of Dallas?
So it's equal distance between Dallas and Oklahoma City. So about an hour and a half of both,
Hey,
about 85 miles or so.
in New York traffic, that's what about 6, 7 blocks.
Exactly.
so you know, so yeah, you're very close to either city, halfway between. So Dr. Ramirez, welcome to the program.
Thank you.
So you know, we have worked together for geez, I don't know. 10, 12, over 10 years. Let's just put it at that. We'll put it over at 10 years.
Indeed.
And one of the things that I've always marveled at in working with you, uh, having the opportunity to be in the operating room with you in your clinic is just the innovation. I always think to myself, there's anything that's new that is coming down the pipe. You somehow have your fingers on it. It's an amazing thing, and I really love that about you and your practice. So, um, a woman, what's your talk to me about your patient profile because you're kind of in a unique location, right? South of Oklahoma City, north of Dallas, but you are busy. So the women that come to see you, what are they really? What are what's the reasons why they're making those appointments? And we're going to dive into it a little bit today.
Of course. So definitely interesting location and very interestingly how kind of migrated into doing the practice that I do now. I mean, as you said, 12 years ago, I was bread and butter OBGYN. But what I knew even prior to going into medical schools, I was an occupational therapist, and I knew there was a lot going on in the female pelvic floor that we weren't doing anything for. I mean, our approach as OBGYNs and standard of care was very limited in prevention or rehabbing the pelvic floor after injury of surgery or even after the natural vaginal deliveries. So as an occupational therapist for the longest, I was thinking to myself, what things can we do differently to decrease that pelvic floor dysfunction as well as sexual dysfunction? And that's the passion that drives me into understanding technology and bringing in technology into my practice to help those things. So majority of my patient, although I'm a cosmetic gynecologist and I do a lot of body contouring and all that stuff, majority of my patients come into my office for my pelvic floor expertise. So I take great pride in seeing a patient holistically, understanding the small everyday things that get in the way of that pelvic floor healing, as well as remodeling or even improving. So I like to look at our patients completely, sleep, the three big pillars, sleep, nutrition, and stress mitigation. Once we get a really good understanding of our patient, understand their hormone balance and all those things, then we take a really good look at the pelvic floor. Most of the times, the patients are talking about vaginal dryness, vaginal laxity, incontinence, whether it be urge or stress incontinence, loss of sensation, loss of libido, and all those things. In the past, I must tell you, 12 years ago, all I had was a knife. So when someone came in, I had a knife and then a hormone that I was crazy scared of, right?
Right.
So it limited my ability to help. But I must say that at this day and age, with the amount of technology, I take great pride of speaking about improving sexual health, improving vaginal laxity, sensation, and lubrication without the knife, also improving the aesthetic look and overall feel and confidence of that patient just from our approach.
So let's talk a little bit about libido, right? There's all these reasons why um, women and men, of course, have a reduction in libido, and so what are some of the what would you say the signs and symptoms are for a woman's libido where you can say, hey, uh, we can fix that.
Exactly. So it's like, as you alluded to, libido is very complicated, especially in women, because it's multifactorial. The first thing you have to delineate is this loss of libido having to do with a history of pelvic pain or some type of trauma that this patient released that we need to figure out how to kind of rewire that brain's thinking of what's going on, or is it an anatomical change? Is it a loss of libido because of lack of hormones? And what we're seeing that most of the times at the age of 35, women's hormone, especially testosterone, which most women don't understand that they have a level of testosterone, their normal testosterone drops by half. And it's at that time women start not sleeping well, not losing weight as easy. Their appetite for sex decreases, and it just becomes their normal self. And over time, that becomes a real issue. So the first thing I like to look at is the hormone balance. Once we get that hormone balance all together, then we have to really take a look at the atrophy in that vagina and all the other issues so that we can improve that into sensation so that patient can be back and successfully enjoy her sexual life.
So, what are some of the techniques that you use to help get those levels back up?
So we have access through all the different hormones. I like bioidentical hormones.
Okay.
And the reason I like bioidentical hormones is because they look, they act, and they feel like the same hormones that your body used to produce.
All right.
And
So,
we
so
think,
pause there, because
yeah,
we're talking to ladies out there, and they're gonna start googling bioidentical hormones, right? So let's unpack that a little bit and say, hey, what does that mean?
yeah. So what that means is, so all hormones that our body produces actually starts off with a cholesterol. And then it goes through a number of different enzymatic approaches that breaks down and gives us the different hormones, progesterone, estrogen, cortisol, testosterone, and all those things. So a bioidentical hormone is taking a cholesterol outside of the body and it's running through that whole entire enzymatic approach to at the end you have a hormone that looks exactly what your body could produce versus synthetic hormones.
Okay.
They're actually engineered um, in lab to look similar to the hormones that we used to that our body produces.
So what are they? Are they gonna? Is it a pill? Is it a cream? Is it an
So there's
injection?
So there's a lot of different forms. That when it comes to testosterone, um, even though there's a ability of replacing it with injections for women, I don't like that because the levels can get a little higher than they should. But what we like is pellets is
Okay.
one form that we like. We like creams also if the patient tolerates the cream. Oral testosterone is an issue because it could damage the liver, but we can do troches sublingual. So there's an excess amount, all kinds of different approaches depending on the patient. And that's what's important too, is that you tailor make your therapeutic approach to what fits that patient and not a general population.
Got to have compliance, right?
Indeed.
All right. So don't. So we get the woman's hormones balanced, right? We get them back to uh, age 30 again. So we fix that, but we've got some other things that are going on, from maybe a dryness to, maybe they do have some slight prolapse to maybe they have some stress urinary incontinence. What are some of the things that you do in office, technology wise, that you think about and have at your disposal? We could share with these
So,
these ladies.
so yeah, I mean, yeah, that's usually the process. The process normally is that we get their hormones balanced, and then they become sexually active, and then they come back to us with some type of symptom, what have you, whether it be stress, incontinence, dryness, loss of sensation, and all those things, or weakness in that pelvic floor muscles. We have the capability of treating all those symptoms, minimal invasive or non-invasive at all. You got to think of the pelvis of three different tissues: your muscular pelvis. You're going to have your subq, the space between your muscles and that lining, that mucosal lining is also very important. That's where all your vessels, your nerves, and all the connective tissue is. And then the mucosa itself. So when a female comes in, let's say, and her biggest issue, she's 45 years old, she's having stress incontinence, laxing her vagina, she's had three babies, then it behooves us to treat all three of those tissues. So we have first in our platform that we use, we have an EMS device that strengthens those muscles. A lot of patients, when we ask them to do a Kegel, they can't even feel those muscles. They can't feel them. And the reason for that is that when they were injured, they were sent home with the idea of do your Kegels and everything be back to normal. Well, if you can't feel the muscle that you're contracting, you're never going to be able to get anywhere with it. So
Right.
we retrain those muscles. We actually basically re um, reintroduce that muscle strength to that patient so that they can continue using it.
So pause
Then
there
we do.
because you
Mhm,
said so EMS device,
correct.
right? So what is that?
So the
How does
platform.
that work? How would you describe it?
So basically, we take a. It's almost the best way. It's almost like an egg-shaped
Okay.
device that has negative and positive electrodes on it that sends an electrical wave into the introitus, right into the interest of the vagina, and it causes those muscles to contract. Right, so it basically wakens those muscles up and allows that patient during that time to understand, oh, okay, those are the muscles we're talking about, and then they're more apt to contract them and be able to follow those Kegel guidelines. But that by itself, truthfully, Rob, it doesn't work as well as when you combine it with radio frequency.
Okay.
So
So
when you combine EMS to radio frequency, what you're doing now is that you're heating up just like an athlete heat warms up and stretches prior to lifting or exercising to get that muscle primed up to the best place where it can contract. Radio frequency serves as that warm up. So we're
so
capable of heating up all that muscle.
so that would be like similar to those devices that you get injured, you're at the orthopedic, and they go, hey, we're going to help you to treat that injury. We're going to put a little gel on there, right? And now
Exactly.
we're gonna
Exactly.
rub this, and it's going to feel a little bit
Exactly.
warm, right? So that's your
So
radio that's your radio
that's
frequency.
that's exactly it. And what that does is that you take it to a temperature about 42 degrees Celsius, and that 42 degrees Celsius in the body it mimics an injury. So it allows the body to respond by sending in fibroblast, which brings in more vascularity, more collagen, more elastin, and improves that subcu space, that space between the muscle and the mucosa that I spoke about. So that's the next portion of that pelvic floor rehab, which is important. And the third is making sure that we absolutely treat the mucosa. The mucosa is the lining of the vagina. As patients get older and the decreased estrogen profile and decreased hormones, that lining gets thin. So what happens when the lining gets thin? A lot of different things. One, you increase your risk for prolapse, incontinence, and things like that. But you also change the pH in the environment of the vagina. When that happens, then you're having recurrent UTIs, recurrent BV, recurrent infections at all times. Um, that's the other thing is loss of sensation as well as some painfulness as well because it becomes so dry. So what do we do to stimulate that mucosa? No, back in the days, all we had was estrogen, which estrogen did pretty good, but not well enough. So now what we're doing is that we're taking and we're using an ablative energy to cause the same response of a thicker lining, so more cells with more cytoplasm, more innervation as well as more blood flow. So now that the lining gets thicker, you get more lubrication, you get more sensation, and you get a tighter, more functional vagina. Um,
So
so prior,
you'd kind of describe it as a vaginal facelift.
exactly,
So
exactly. It's like a vaginal. Yeah, it's exactly what you're doing. You're basically making that. You're bringing back that mucosa to a place where it's functional again. The pH improves, so you don't have recurrent UTIs and infections. You have a better, less laxity, so you get less prolapse, less issues down the road. You get more sensation, more lubrication. So now that I've increased your libido, now you have a functional vagina as well that works.
so what? How would the patient present to roll them back to the operating room? What's that? What does that look like?
So the neat thing about everything I just spoke of, we don't have to go to the operating room. These are basically three treatments, 1 month apart, that take about maybe 30 minutes in the office. They're awake. We do local numbing, and those patients can get up, walk out, and go back to work on that day for those treatments.
Yep.
What just to kind of clarify the different energies in the vagina, prior to having the depth that we're going into now, which I'll explain, All we had was like CO2 and also monopolar, which which was difficult to control the energy in monopolar. But CO2, the only depth that we were going to was zero point 0.8 millimeters, which that zero point 0.8 millimeters did a good job for lubrication, but only lubrication alone. Now we're able to go 3 millimeters, 2 millimeters, and 1 millimeter. And what we're seeing, on top of all the things that I just spoke about, we're also seeing an improvement in urge incontinence, like an 80% urge incontinence improvement, which is huge because that's the part of urge incontinence. If you ask any woman in the world that has incontinence and you say, which one do you hate the most? Is it the urge or the stress? So the stress is when you cough and sneeze
Yep.
and things come out. Most of the time, you know it's coming, you can cross your legs, you can mitigate it, right? But urge is all of a sudden, next thing you know, your whole bladder context empties in your pants, and voila, not fun.
So that you
Um,
describe the urge is I have to go to the bathroom and I have to sprint because I
yes,
can't
but you can
hold it
never,
in. I
yeah,
can't. I
and
can't.
it's very seldom you can outsprint it. So you normally have an accident. And then all we had was medication. It had a ton of side effects to it, as well as we were implanting like pacemakers. But now with this 3 millimeter depth, what we're seeing is that we're capable of decreasing that urgent continence, and we're theorizing is because we're downregulating those afferent nerve fibers at the neck of the urethra.
So let's back up because there's probably a lot of women that are taking medication for urge, right? So
Yes,
because they
large percentage.
very very high percentage. Um,
Mhm.
what are some of the known side effects for that medication for urge, and then we'll kind of talk about how we can maybe get them off that medication.
So the first generation medications that they came out with, the biggest things was just dryness that have oral dryness, eye dryness, that have constipation, just horrible side effects. They didn't
Right.
like it. Most of them just stopped it. The second generation that we've seen now don't have that much dryness, but we're seeing that you have to be careful if you have a history of high blood pressure and things like that, that you have to keep a really good eye on that because it can cause your blood pressure to go higher. So I believe those are real side effects that if I can treat a patient without those side effects, then it's a home run.
So, what's been your success at women that come in on medication? Are they able to stop it
Yes.
altogether, or reduce it?
So out of 10 women that come in on medication for urgent continence, about 8 of them are able to stop it. The other two is pretty, their issues have been pretty severe. But I used to do a lot of Botox injections in the bladder. My Botox injections in the bladder have decreased tremendously. I hardly ever do them anymore because I'm having such a great outcome with my vaginal Morpheus.
That's amazing. So 8 out of 10. That's a fantastic
Right.
success, especially for something that's only been controlled with medication. So you've been doing this for how long? Year, 2 years?
So the vaginal Morpheus came out about 2 years ago
Okay.
now. Prior to really having that handpiece that's made for the intravaginal, I was taking the handpiece that we were using outside on the face and having patients bear down because I knew it could actually cause a lot of different changes. And during that time is when I saw the most changes. Is when I was doing it with a handpiece and I saw patients coming back and telling me, "Listen, I got great feeling, I got lubrication, and Lord of behold, my urgent continence is gone."
Right.
Bing, the light goes off, and it's like, wow, this is great. And here we are now, 2 years later. We have a device that works much better in the vagina, and it's showing a great deal of improvement.
It's kind of like the Viagra story, right? The side effect.
Yeah,
It's like, hey, hand your medication in. They said, no, no, no. We want to keep it.
this is good stuff. Yeah.
The side effect
So
was
yeah, so let's say the patient comes in. Let's say none of that works, and like most of the times, the hardest thing to treat, as you know, is stress incontinence because that's an anatomical issue. A lot of different variables, whether it be the patient weight, the amount of scaffolding and support that they have in that pelvic floor, the amount of descent in that bladder. It's hard to take energy and make that go back.
right.
So because I have a lot of technology, we also have things to do prior to going to surgery. That if it doesn't work, it prepares that tissue for us to put in like a biological mesh that's going to retain is going to help. So I'm really excited about the idea of going in and heating around that urethra
Yep.
because that takes that patient that's having stress incontinence and it's improving them. For some of them, enough that they may not have a surgery, but the ones that do need surgery, it actually prepares that tissue for good placement of whatever we need to use.
Right. Right. No, no, I love your approach. I think uh, it's very effective for these women, and it kind of walks them down this path that okay, if we need to go there, we can, but we don't, always have to.
So, I mean, so mostly what we've spoken about has been, people that have now they've come in with a symptom. The biggest bulk of what I really want to make the biggest changes is those patients to keep them from getting to that pelvic floor dysfunction, right? And those are our patients or women that are early on after vaginal delivery that that everything that we've done up to that point has gotten in the way of their healing. So standard of care for women when they have a vaginal delivery is that they put them on high dose Motrin. So they knock out all the inflammation because what we're worried about is breast milk, right? And the baby getting the proper breast milk with no narcotics or anything like that. But never mind how the pelvic floor is healing. It's going to heal. It's natural, right? Not so much. So what happens is when we see them 6 weeks later in their postpartum visit, they have a gaping open vagina. They can't Kegel, and our standard of care is go home and do Kegels when you're at a stop every stoplight and every commercial, and then we just losing the follow up. Grandma, great grandma tells them along the way, "Oh, you're having incontinence. It's okay. It's normal, baby. Be blessed. You had a baby."
That's right.
Well, those same patients, if we're able to realize that patient absolutely need pelvic floor rehab after an injury like a vaginal delivery, we can decrease that 70 to 80% pelvic floor dysfunction that we're having
Right.
in the United States right now. So it's something that needs to be heard, needs to be moved. Something needs to change in the way we approach women, and I think we have the technology to make that difference.
Well, we're certainly making a difference today because we're getting this message out to all these ladies from around the country that it's so important. To your point, after your vaginal delivery, even having a C-section still puts so much pressure on your pelvic floor, right? You can just you just imagine. Here you go. Here, put put this 10-pound turkey you know,
Exactly.
on the top of your vagina.
As well as when we go in and we cause trauma through surgery, when we do a hysterectomy, why aren't we doing pelvic floor rehab afterwards? We're injuring that muscle. We know it all turns off because of pain.
Right.
Then we're just releasing them after 6 weeks. Those patients need pelvic rehab. If we're doing an anterior posterior repair, those patients absolutely need it. So we've just got to change our paradigm and how we approach the pelvic floor. And I think these 70 and 80 numbers of pelvic floor dysfunction we can decrease in time.
Yeah. No, I certainly agree, and I hope that women that are listening to this and will take that corrective action. And the good thing about women is they they definitely own the healthcare, right? So many times they're the one that make the decisions in the family, and they're certainly very responsive to what they need. We just have to be better at educating them and say, hey, we can help you. This is not normal. This is normal. This is normal, but we can fix it.
Yeah,
You know,
what we need, you're correct. It's absolutely not normal that you're leaking, but what we need to normalize is their ability to speak about it.
right, right. And
So a lot of them are being
and
told,
that there's a way, there's a pathway, and it doesn't always involve surgery. That we can get you on a better path. My dream would be to not have to walk into Costco and see an entire row of Depends for every size of adult. Um,
I just heard a report where Depends is going to outdo Pampers, newborn Pampers here in the next 2 or 3 years. So the issue is a lot bigger than we're willing to speak about.
right, right. there's a pathway to better health, and certainly there's a pathway to having that freedom of not having to a try to outrun the bathroom, that cold
Right.
sprint, or having to align your entire day around where all my bathroom breaks are.
Yep.
Or
Yeah,
I can't drink any water because then I'll have to go to the bathroom.
exactly.
So that,
Never mind. Stay off the trampoline. No jumping jacks.
right,
All those things.
all those
So,
things.
oh,
Well,
yeah.
listen, Dr. Ramirez, you have really helped out a lot of women with your innovative approach. I hope that this podcast will give them another avenue to come out and connect with you. Uh, tell me your website. Southern, right?
So my website is Southern Oklahoma Women's Health.
Yep.
And yeah, you can find pretty much everything about me there. I also have an Instagram is Living Well MD,
Okay.
which kind of you see kind of what I'm up to. Where's Waldo? That's where you find me is there. But yeah, thank you so much for having me on here, and I look forward to collaborating and getting this word out.
Absolutely. So thanks for joining us. Have a wonderful weekend, and I look forward to having you back on the program.
Indeed, take care, bud.
All right. Bye bye.